So why I'm here today, I've been very fortunate over the last couple of years to have quite a lot of education through the Victoria Hospice, as well as several courses that I've taken online with palliative care. And so my basic learning goals at the moment are to help provide better care for individuals receiving palliative care in an acute care setting. And as Dr. May said, almost 50% of the population is dying in that setting, and that's where we need to really improve a lot of our care. And also to help facilitate educating my colleagues about current palliative care practices and what's appropriate for our area of work. So I'm going to jump straight into the all care brochure that you see in front of you. So this campaign was launched in order to help educate the community about what palliative care is, the benefits of early palliative care support, and aims to change the perception that palliative care is only about death. So the brochure defines both supportive palliative care and hospice palliative care. It defines goals of care and provides information on who to contact regarding palliative care. And it also allows the public to read the information and see the term palliative in a new light. So the brochure was just released, went out to the physicians on January 17th and came up to the hospital on the 18th. So if you look at the brochure at the two life journeys that are shown, there's several definitions on that page that I'm just going to kind of go over to help explain what they mean. So the first is the supportive palliative care, and that is appropriate at the time of diagnosis and while a patient is still undergoing curative or life-prolonging treatment. And the second defines hospice palliative care as care provided at the end of life when treatments have been stopped and as bereavement support. So when the group was going over the themes for this campaign, changing the conversation became sort of the main theme. And even though this is based for the general public, I just thought how important this is for nursing staff in general. I think most of us who have worked in an acute care setting and probably in the community as well for several years have associated the word palliative with dying. And that does really need to change, and I'm just going to give a demonstration why. So just for an example, an MSP admission that you may get. It's a new admission, a 57-year-old male named Mr. B. You speak to the ER nurse and the diagnosis is query small bowel obstruction, and the other diagnoses are hypertension and stomach cancer. Prior to hanging up the phone, the ER nurse tells you, it says here he's getting palliative care. So when the patient comes up to the floor, there's quite an extensive list of orders. So he's had x-rays, he's got QID vitals, he needs a CT, he's got an IV, he's got labs for the next few days, and the most form indicates that he's a full code. So the patient is nauseous and also needs an NG tube. And you see in the doctor's notes that pending CT results, he may request a surgical consult. So what happens now? I think all of us have seen it and all of us have thought it at some point, and it goes something like this. That sure is a lot of intervention for a guy who was palliative. And worse, why bother? Why bother putting him through so much? So as you can see, this is why we need to sort of broaden our perspective of what the word palliative means. Things we don't know at this moment. Maybe he was only diagnosed 3 weeks ago and he's asked to have some supportive palliative care in the community. Maybe he's been given less than 6 months to live, but maybe he'll make a full recovery. And in all of those scenarios, palliative care is appropriate and beneficial. So how do we kind of get through this barrier? And of course, we're going right back to Nursing 101 here, our big favorite word, communication. So communication between patients and nurses and physicians and anyone on the care team needs to be detailed and clear as it greatly affects the quality of care we provide. If you're not sure, ask for clarification. Is there an order for comfort measures only? Is the patient receiving supportive palliative care? And is the plan to go home after the patient is stable? Get comfortable using the language. Start using the terms supportive palliative care and hospice palliative care in your practice. You'll become more familiar and comfortable with the terminology. An example of this might be when we're putting in our diagnosis into Meditech, that we're actually defining if they're receiving supportive or hospice palliative care, and that will be a big differentiation and change how we look at things. You'll have a better understanding of your patient's needs. So I found this quote, learning another language is not only learning different words for the same things, but learning another way to think about things, which is what we're trying to do with this palliative care campaign. So when our own interpretation of the term palliative relates only to death, we deem many of the medical interventions as unnecessary, and we sort of get tunnel vision when we're caring for these people. And of course, advocating for our patients is extremely important, but our personal perspectives on what treatments are necessary or not should never overshadow what a patient's goals of care might be. So I'm going to cover again what Dr. May talked about with the goals of care, and it's defined on the brochure as decisions and plans about a person's care and treatment based on his or her desires and fears for the future, and they can improve quality of life and death. And why are goals of care so important for us? Because it provides the foundation for the patient's care plan. And with that, it allows us to tailor our care to appropriately to the individual and allows us to focus on patient-centered care. So even though with our daily assessments, some of the things that Dr. May talked about, using the ESAS or the PPS, doing a pain assessment, maybe we'll be doing these things every day, but the delivery of care will change based on a patient's goals. So for a quick example, someone that comes in might rather live with some pain and have more awake hours, and over time, when that pain becomes too great, their new goal of care may be have no pain, even if this means the patient is asleep more. Something else that we need to feel a little more comfortable is it's okay to ask. It's okay to ask your patients what their goals of care are. What are their end-of-life wishes? You spend a lot of time with these people in a very fragile state of their lives. Asking provides them comfort, it improves quality of care, and it improves cohesiveness between the patient and the nurses. So the palliative care support campaign, the brochure is out there, it's up on the floor. Read it, use it, get yourself familiar with it. It's a great tool. And of course, if you have questions about it, certainly ask.